Okay. Hello. Good morning to you all, one and all of you. Thank you very much for attending today's session. This is kind of the graveyard session on the third day of the virtual conference of the South African Medical Association. I'm Dr. Omar from Durban. I'm very honored to be able to address all of you today. And what makes it more interesting is that I'm addressing you against a backdrop of critical patients that are in our practice currently. I've taken time out to say hello to all of you, and I've taken some time out to be able to share my experiences, my understanding of what I think may be important elements towards making private practice feasible in the context of a pandemic, in the context of widespread disease and ill health. So thank you very much for attending this. I'm sure you've had 2 full days or 2 days already of serious clinical, epidemiological, and ethical sessions. My session is looking at how we can sustain our private practices, how we can make our private practices viable, how we can make our private practices relevant, and how we can ensure those that are intending to enter private practice from our new batch of colleagues coming off medical school, that they will look into private practice as a viable and a relevant way of addressing the healthcare needs of the South African population. And those that are having issues around existing private practice, feasibility and viability, I'm hoping that my presentation this morning will encourage you to continue with private practice and use the ideas and challenges and experiences to make your own practice feasible for yourselves. Next. So we can move forward, Lloyd. So how do we unpack this topic? It's a vast topic. It's you know, we can speak hours over this this concept of private practice and its feasibility in the context of the pandemic. One back, Lloyd. What is our topic all about? Our topic is about private practice and what is it? What does it really mean in the context of the pandemic? What it meant pre-pandemic, and what's it going to mean post-pandemic? Then I'm going to very quickly unpack the pandemic in the way that it has impacted on the way we practice and the way we're going to be practicing in the future. And finally, and which is the main core of my presentation, and which is the heart of what I'd like to share with all of you today, is how do we make private practice feasible in today's times? What are the elements of feasibility during a pandemic? What were those feasible elements pre-pandemic? And how are we going to take private practice into the post-pandemic world of private medicine or of healthcare generally, locally, generally, nationally, and perhaps globally? Next. So private practice has always been considered a for-profit moral enterprise. Private practice has oftentimes been considered from a management point of view in terms of its profitability, in terms of the revenues that it drives, in terms of the fixed and variable costs. Those were always the cardinal principles of any practice management. And they're relevant to most industries, to most practices, and to practically all for-profit enterprises. So what makes the private practice a moral enterprise or an enterprise with a difference? And the issue is that in private practice, your clients, our patients, and in some contexts, we'll call them customers, they are a group of consumers or clients that experience ill health, disease, and suffering, undergoing anxiety, pain, discomfort. This is the market, this is the population This is the group of people that we serve. And so private practice, in effect, is taking the diagnostic clinical model as we've been trained in medical school and finding an integrative way of serving the patient population in such a way that it provides some form of revenue and profitability to continue practicing medicine in the context of private healthcare. So that's generally been the way private practice has been designed over the years, and that's how it's been practiced in our model during the HIV epidemic in South Africa, and TB and various other communicable diseases. We'll move next now to what has happened. So when we talk of a pandemic, we're talking of a condition, of a situation that has been defined as a public health emergency of international concern. We've never had such an announcement in the last 100 years or so. We've never really truly been trained in medical school in terms of the clinical models and the management models of practice management or patient management with algorithms for pure pandemic conditions. We certainly did many courses in community health, in the disciplines of family medicine, in terms of managing conditions whereby communities are in effect diseased, where we have to look at a population perspective of your practice. And hence, this pandemic, I say, is possibly going to be with us for a good few more waves. And we need to ensure that our practices are designed to be able to manage the various waves that are going to be faced as we go along. So one of the major things that has happened with this pandemic is that it has disrupted the traditional way we delivered medicine to our practice population. And that's something that we need to be very cognizant of and really need to take note of in the way we design our practice and the way we manage our patients and the way we resource our practices. So that takes me to the final slide within the first element of this presentation, which is the first part of the presentation, where I'm just going to give you some context in terms of unpacking this topic, is that, and which is the crux of why I'm here this morning. And the crux is this: how do you make private practice profitable? What are the elements of private practice profitability? And we do know, and the management textbooks are replete with models and examples and methodologies of practice management. But my presentation this morning is clearly taking a truly innovative approach. And it's about taking the emphasis away from private practice per se as an enterprise, and about making private medical practitioners rescope their clinical practices. And here's the operative word here. We're looking at rescoping our clinical practices such that in effect will have a profitable impact on our private practices during this pandemic. So ultimately what I have done, what I am postulating and hypothesizing for my colleagues in private practice is effectively what I have been doing for my own private practice to remain sustainable, to remain viable, to remain relevant, and to be profitable in the last 18 months that we've had this pandemic. So ultimately, what am I saying? I'm saying that I want to make the private medical practitioner's clinical role feasible, because it appears to me that we need to get back truly to the true medical doctor as he's been 100 years ago, and redefine himself or reinvent himself as the clinician of choice for managing patients in a private practice setting. So with all of this jargon of defining and re-explaining, I want to set the tone and I want to set the scene for the rest of my conversations around how I can give and share some actionable, practical steps in modeling private practice to be a feasible venture, to be a feasible enterprise that's for-profit orientated, but at the same time has the crucial element of being a moral business, a moral enterprise, and an enterprise where one feels that one has served humanity, one feels that one has served mankind, one feels that one has served one's clients, but at the same time having a for-profit as a in inverted commas as a side effect of the practice of medicine. So can we please have that video going? And essentially it's a thesis of saying, it's my thesis that we have to move into a new model of virtual real-time medicine, and such virtual real-time medicine, which I've been reading much about in the last 20 or 30 years about, seems to have now come together in the form of my presentation, in the form of my practice in this last 18 months. Relax, it's a 3-minute video. I'm running an ICU in Durban as well as ICU in Victoria. And you must take instructions from the control center. You mustn't take instructions from the patient, my brother. I finished speaking to the paramedic long time ago. I want Mujib to come to the site, to the hospital site, to ensure that whatever I say gets followed through. The dynamite and sodium of the iron ore is 1.19. The APCC is at finish state. Okay, as soon as it's done, can you call me, please? It's very urgent, ma'am. City Hospital, do I have a bed in ICU for me, please? For a bed in ICU, please, for a male bed. A high care, sorry, not ICU, high care. We are losing time. All right, thank you very much, friends. colleagues for bearing with that video, which was made during our training program in Wave 1 last year, and which was used extensively for colleagues who wanted to also redefine their medical practices, their private practices, where patients were having difficulty finding their getting into their practices due to the transport and the lockdown issues. Essentially, this was a model of taking private healthcare, private medicine from a GP practice perspective into the community, using an HPCSA modeled delivery program embedded with indemnity waivers from the Medical Protection Society for out-of-scope practice. Ultimately, the reason being that had I stayed within my own private practice, the way I've been for the last 20 or 30 years, and wait for patients to come to me, I probably would not have been viable or sustainable or feasible in the last 12, 15 months. So I had to do something to ensure that I have to take my practice to the community. The first thing. And the second thing that I had to do was also adapt my practice to now not being the GP who sees patients walking in and in cold, chronic subacute cases, but practical requirements of the need of the time. And the need of the time was oxygen. The need of the time was intravenous dexamethasone. The need of the time, especially in early wave 1, experimental drugs. All of that we stocked so that we had in our armament drugs and medication that could be used for our patients. So effectively now, following on that, the video effectively identifies, yes, thank you very much for the slide. So what's my conclusion of this video and this photograph? The company car of the doctor is essentially, we got to go back, Selby. We're looking at a new generation of a medical practitioner. I've had to redefine myself. I've had to reskill, retool. And essentially, I want to be untethered from the physical practice that I've been used to over the years. The pandemic has got me to the point where I've realized that I'm going to take my practice to the community and into the community. And even if it means during the times of surges and wave peaks, and also thereafter, when you're in the trough of a wave, to revert back to your practice. And the secondly is that I've got to ensure that I can take my services into the homes of patients, which I call alternative care settings. So my practice in effect, is not just my practice within the boundaries of my physical infrastructure. My practice extends into communities and into the homes of people. And I think what I've demonstrated for myself and for my patients, that I've now made the doctor's office a mobile office, and have made the doctor's practice site the patient's home. So following on that, I want to then now get a bit theoretical again and look at what the literature, what do the management textbooks say? What was the pre-pandemic model of feasibility? And I think that slide needs to come on in terms of saying, what do we do to make a business feasible in general, which applies to all industries and for all moments. We measure, we control costs, we measure our outcomes. We want to balance the interest of the profession with the interest of making a profit. We're constantly looking at ways of serving our ideals of the Hippocratic Oath that we attest to when we qualify as medical doctors. We want to balance the interests of people that are suffering, that have issues with affordability, with the need to keep a practice feasible. Then we're always looking at a model where we can increase volume, we can increase scale, we can have economies of scale and lower pricing structures, where we can reach out to a larger market. Then finally, we're always competing with our colleagues in terms of providing excellence in the services that we offer, but we do that in a cooperative way. We do that in a collegial way. We do that in a way where for ourselves, we identify our strengths in our practices and we hone in that, and we share our strengths with our colleagues, and we expect our colleagues to be able to share their strengths with us so we can co-create a management program or a clinical program for our patients in such a way that we are, providing a viable private practice service to our patients. So that's how it's been all along, and that's how it's always going to be. And it's always, these elements are always going to be there. But in a pandemic situation, and that's where we come to the next slide. And in a pandemic, in the age of a pandemic, where you have widespread disease, widespread ill health and suffering, we need a paradigm change. And I know every speaker is going to have a paradigm change because that's what makes the speaker relevant generally. But I believe that we need a new paradigm, and I would call it for pandemic healthcare. This paradigm is going to be preemptive. This paradigm cannot allow a patient to be managed only when symptoms surface. We know from COVID-19 that prior to shortness of breath, prior to symptoms of hypoxia, we're finding the patient has got an oximeter reading of 85% or 80%. So we've got to be preemptive here. We cannot use the classical symptom-based or symptoms-based management of a patient. You've got to be very comprehensive. You can't tell yourself that you are a GP and therefore you're going to find refer the patient to a specialist. You've got to take decisions on your own. You've got to work with specialists. You've got to work with other colleagues. You've got to comprehensively manage your patient. Resources were limited. Bed capacity was limited. Staff shortages were limited. So these are concerns that I don't need to have a conversation about. Each one of you has had family members who may have passed on. Each one of you has had family members or friends or colleagues who have experienced the breakdown of the private healthcare system in South Africa during wave 1, during wave 2, and currently in wave 3. So we need a multi-tiered clinical management. A private practice has got to get out of its old discipline-specific model of management to be able to manage patients on a multi-tiered level: primary healthcare, secondary healthcare, tertiary healthcare. These three domains, traditional, conventional domains of medical services, which very oftentimes were relegated to different spheres of healthcare management. These now coalesce together during this pandemic into a unified private practice approach. So how is this new paradigm implemented then in private practice? How do we implement this? How do we take this forward? How do we take the theory of implementing this new paradigm in a private practice environment, in the sense with private practice, in a private practice model? And so our next slide will talk about the new era of healthcare. And it's not about something in the future. This new paradigm is not something that's going to come along. This new paradigm has already been with us. I'm just taking it and formalizing it into a presentation. I firmly believe that there have been many, many doctors, many, many colleagues, private practitioners who have been applying all of these principles. My power here, have been applying these principles in terms of managing their patients in their private practice. So I know of urologists, I know of dermatologists, I know of people, I know of surgeons who are managing wards in hospitals. I know of, neurologists who have been looking after COVID patients and the chest problems that patients have been experiencing. So I believe the private practice of the future, the private practice in pandemic times, has got to be a learning practice. It's got to be a practice where one's got to get back to the medical school. And how do you get back into medical school 30 years having left medical school? And obviously, the whole concept of virtual medicine will come in, where I talk about the concept of the virtual medical school. So what are the 4 cardinal elements of the new era of healthcare. And I see it in the following: patient profiling, knowing your patient, knowing who you're serving, knowing your practice's patient market. The second thing is predictive and proactive management. Management that does not wait for patients to be ill before you start attending to their problems, or before you start calling them, in inverted commas, your patient. Your patient is your patient the moment he's registered at your practice. And your management of the patient starts before the patient falls ill, or before the patient perceives that they are ill. And so that will take on now to what I call the third element of feasibility. And I call it the personalized prioritization of patients' treatment needs. Now, these principles have been around for decades now. And I think most departments of family medicine and current thinking in pre-pandemic thinking in universities and teaching school would speak to various parts and aspects of this of the 4 Ps that I call the quadruple P of pandemic. It's not by chance that they all Ps, and the pandemic had been P. Private practice is 2 Ps there. So we look at patient profiling, predictive and proactive management, personalized prioritization in private practice in times of a pandemic, and finally, of course, the issue of precision intervention. And all of these 4 aspects that have been practiced in various forms over the years, I have taken that and essentially put that into into what I call my model of private practice feasibility. So let's very quickly go through the next slide and talk a little bit about patient profiling. And I'm very sure that there are many of you colleagues out there who know much more than me in each of these topics. All I've done is just taken the source and just glued it together and put it into a viable model of practice management, of practice feasibility, and of managing my patients in a way that my practice is profitable, and at the same time, I'm reducing ill health, I'm reducing mortality, and I'm serving people. So you got to know your patient before your patient comes to you. You've got to risk profile your patient base, your patient market, your patient population. On an individual level, you got to be focused on biomarking. You got to be focused on using technology. You got to be focused on using external additions to your clinical decision making, where available, of course. And then where not available, we need to start investing in ensuring that you don't have a CT scan centralized in a regional hospital. You should have a CT scan in your clinic down the road. So if you don't have the expertise to run the CT scan, you can have your CT scan images zoomed or wired to India or to America or to a central repository in Cape Town. So we need to start investing in taking tertiary healthcare in inverted commas, tertiary equipment and resources, and putting them out into the community. And I think that's the crux of private practice now. And so you need to know your practice. You need to be able to stratify your practice. You need to be able to build a pyramidal structure of your practice. And you need to see what are the issues in profiling your practice, and at the same time, profiling your patients. So in terms of our wave 1 model, we've had to profile our patients so that we were able to, we can go to the next slide now, so that we were able to identify and predict where they will fit in terms of management of their condition. So what does a practice do? A practice has got 2 components. It's got an element where it attends to immediate patient needs, and it has a component where it's got to look at itself as a business, as an enterprise, and it has to be able to develop for its population base factors, using data analysis, using the actuarial models that we learn from other industries, and we're going to bring that into our practice and identify and be able to label your practice. And you look at the next slide there and see what does your practice do in terms of predictive and proactive management? How does your practice fare? So what we did, we also then created our own practice clinical models. Now remember, in March 2020, We never have any algorithms or management guidelines from any of our associations at that point in time. So we had to find ways of creating and understanding the pandemic, understanding the individual impact the pandemic is having on our patients, and being able to then ensure that we know our patient's condition before they end up into what we call the severe zone, where we find that high resources are required. And that is why, as you go more towards the right of this graph, the resource requirements are far higher. Whereas as you in the beginning of this graph, you'll find limited resource need, low resource requirements. So if we are able to keep our patients away from ill health, if we are able to preemptively and predictively manage our patients before they go into a yellow zone, then we will be able to ensure that we're not only going to save patients money, but we're going to save the practice from having to resource itself with high cost equipment and interventions. So some examples, again, finally, we go to the next slide and we look at how then do you intervene in the management of a patient in a way that is resource scarce, in a way that does not utilize unnecessary drugs, in a way that doesn't overuse oxygen, because we had an issue with oxygen. So we invested, our practice looked at key equipment pieces that we could resource our practice with. And one simple example was the thromboelastogram machine. A second one was a high flow oxygen device where we could, independently of the flow rate, titrate the oxygen, the FiO2, to a desired level, just enough to keep the patient within acceptable oxygen saturation levels. So in some settings, for example, you'll have a patient who needs 65% or 100% mask. So you actually to keep the patient within an oxygen range. So that's in terms of oxygen delivery. In terms of the thromboelastogram, we found that there's a fine line between bleeding and clotting. And all of this was learned as this pandemic started. So we had to use anticoagulation in such a way, in such a judicious way, so that we don't overbleed the patient, and B, that we have enough anticoagulation and enough resources for us to serve our patient base. Now, ultimately, what that means for me and what that means for our patients is that in terms of managing patients during this COVID pandemic, we've had to reinvent our clinical skills. We've had to reinvent our clinical practice, and we've had to resource our clinical practice in such a way that we de facto created, in the next slide, what we'll call a COVID-19 clinical practice model, and to ensure that it's affordable, it's appropriate, and it reaches a higher target group. We've had to ensure that it is embedded in virtual real-time management. The proprietor of a private practice, or the partner of a private practice, or the associate in a private practice, or the director or shareholder of a private practice cannot be at more than an X number of patients in a day. So using a virtual real-time model of clinical practice gave us this opportunity and gave us the ability to be able to serve our patients in a way, integrating the 4 Ps into what we call the virtualization of private practice. So I think when it comes to what I define private practice as now, I call it a decentralized, highly localized practice or a site where we are identifying patients that are at high risk before they fall ill. And when they do fall ill, we stabilize them either at home or in our practice. And we have the backup equipment and resources, and we have the regulatory support, and we have the indemnity waivers, and we use the concession provided to us by the Health Council in terms of telemedicine to be able to manage these patients in inverted commas in treatment pods or holding bays until we can escalate them to a hospital for the acute care. So we fully integrated remote digital telemedicine protocols. We developed some of these 30, 20 years ago, and we're now putting them to use in an acute setting, in a setting where we practically doing virtual resuscitation and virtual life saving on the phone. So what do we do then? And this is where I want to take the theory out now and get back to a little video again in terms of virtual medicine in clinical practice and how we augment that with on-site acute care treatment in our practice. I think we should have that video going now. Let's look at that virtualization of the doctor's office and how it integrates and how it can be applied. Now this is 25 years ago when we had no social distancing, and this is today in color. This is the past again. This is what we call 25 years ago, the supermarketization of GP practice. And today we are doing the same thing again, but we're doing it on a virtual platform, and we're doing it in a model that's prioritized for individual patient needs. And this is what private practice is about: planning, modeling, analyzing, predicting, managing. Hi, my patient. What you up to?
Okay, just testing this
robotic medicine.
Right.
How are you feeling? How are you feeling this morning? How are you feeling this morning?
I woke up with a slight cough.
Yeah.
But so far, I'm alright.
Right. Do you have any questions for me? Is there any question that you need, anything you need to ask the doctor about?
The first September 26th, so do I come out of quarantine at the 9th of July?
You're now going to be coming out of quarantine on the 10th of July. Alright?
So you'll have a digital appointment. You don't need to physically come to the surgery.
Okay, do I contact you on the digit doctor stuff?
Yes, you're going to use the app that you're going to download from the App Store. Once you download that app, then you're going to use your ID number and you're going to register yourself. Okay? And then you'll get an SMS that will give you a PIN number. I want at least 3 to 4 hours of sunlight per day. You are young and you got no risk factors. So therefore, you're going to just take some Panado if and when you're feeling a bit fluey or you're feeling a bit of body aches and pains.
But what we are saying is that you are now taking responsibility on behalf. You know when your isolation will begin.
Yeah.
Okay, any further questions you have for me, anything you want to talk about, anything you need to know about any issues whatsoever, you know how to get hold of me, you know how to get hold of the app and download the app. Okay, Assalamu alaikum.
So we're not just doing virtual medicine and virtual telephone support and virtual health care. We augment our services with physical, practical examinations and administering of medication as well. I think this is what we need to understand about virtual health and virtual medicine. It's not pure telephonic, not pure virtual, not pure real-time digital, but it's real-time, physical, actionable medical practice augmented with virtual support, or vice versa, depending on which perspective you look at it. So one is redesigning the practice from a physical infrastructure point of view. And the second thing is to redesign the practice from a PPE, pandemic, infectious disease, hygiene control perspective. So I hope I'm actually done with my presentation. Thank you very much. But I just want to share the way forward. I just want to share what we're doing in wave 3 now, where we feel that we've adequately developed the model. We've taken the lessons from wave 1. We took the lessons from high velocity, high flow oxygen anticoagulation models. Then we implemented a redesigned private practice virtual office model. And now finally, we are now into what I call beta testing of the virtual vaccination system. And I think that's going to be very, very new going forward for practitioners, where every practice would be able to be part of the vaccination rollout program, as we have thankfully been afforded the opportunity to be the GP practice, or to be the first private practice, I think, that's rolling out vaccines to both the insured and the uninsured. And I think this is where the critical aspects come in, that private practice is not purely for your LSM 7-8 high income medical aid market or your high paying concierge medicine market. Private practice, to be feasible and sustainable, has to engage in perhaps in what we call non-profit making medical practices and services, to be able to serve your patient practice. And through that serving, one will find then a return on investment, a return to feasibility, a return to profitability by virtue of our practices having a larger, greater patient base. So I think I'm done with my, I'd rather spend more of my time answering some questions, but the next slide will show that this whole concept of, this whole issue of making private practice feasible, the next slide will show that it's not just for the one pandemic that we all are talking about. It's also for another type of pandemic, or we'll call it an epidemic within the pandemic. And we're very thankful as well for having the opportunity as a private practice to be able to afford or perform free TB testing. Again, to ensure that our patients are not already in late stage tuberculosis before we start intervening. We want to intervene before the patient has become critically ill or acutely ill or severely ill. And I'm hoping that such endeavors are taken to every private practice in every part of the globe, and specifically in South Africa. So with that, I want to say thank you all for affording me this opportunity to share my journey, to share my experiences, to share my understanding of how private practice can be made feasible. I try to leave out the theory. I try to leave out all the MBA jargon and the management gurus of the day, and rather share with you my own practical, feasible, implementable steps using an HPCSA model, using the Medical Protection Society as my indemnity support, using the Department of Health's dispensing license, using the collegial goodwill of the South African Medical Association members, specialists in our practice who lended their time to us and taught us how to manage patients, critical patients on a virtual platform. Thank you very much.